I just wanted to start by telling you a little bit about this book that is actually published by the department chair at University of Florida, Michael Oken, as well as some of our other colleagues, about ending Parkinson's disease. When we think about future therapies of Parkinson's disease, you know, it's helpful to have a little bit of a plan to how to get to that point, or how do we think about ending disease and really helping patients. This is a disease that's really increasing as people live longer, as the world gets more polluted, as other factors are at play. We were seeing a lot more people now developing Parkinson's disease, and it's really something we need to pay attention to. So I just wanted to shout out, this book is wonderful. I try to give this to all of my fellows and tell people to read it because it really helps raise awareness to what we're facing and how we can go about really tackling what we're going to do to help end Parkinson's disease. And one of the things that this book does at the end, or towards the end, is thinking about new therapeutics. And so you can get a little bit more information in this book as well about thinking about how we're going to develop new treatments. We do have some treatments for Parkinson's disease, right? We have things like Levodopa, which is a 50-year-old drug now, and it is pretty helpful for some of the motor symptoms, but it doesn't really address the underlying disease, and it has its own complications. So we really need to be thinking about a new generation of therapies that are going to be aimed at not just treating the motor symptoms of the disease, but thinking about how to treat what's going on at the cellular level, the underlying pathology.
Recording in progress.
We also need better ways to measure what we're doing. So if we give a therapeutic intervention, we need better ways to actually say that this is helping or not helping in a shorter window of time. That would really help us accelerate how to, move the field forward. And then we also need treatments that are going to be better to help those who are already affected with the disease, who have significant symptoms, where a lot of these the symptoms that patients with Parkinson's have are not well treated, especially non-motor symptoms, and as the disease is more advanced. This slide is kind of busy, and maybe it will be hard for those to see who are in the room live. But when you're thinking about where we're going, with future therapeutics of Parkinson's disease, it's helpful to see where we've been and to put things in perspective. And so this slide just helps highlight kind of the history of Parkinson's disease therapeutics. And in the gray boxes, it's kind of defining some of the landmark things that have happened with Parkinson's disease, understanding some of the pivotal interventions that have come along. In the purple boxes, it's talking about drugs, therapeutics that have come along, and then as well as treating some of the non-motor symptoms that are coming along in the blue boxes. So there's been a lot that has gone on, and you're thinking back about the last 50 years, despite the fact we have a long ways to go, we are making progress, and there is lots and lots of work happening, and continues to provide hope that we're going to continue to chip away at this disease and find better ways to treat patients. But Parkinson's disease is tricky, and we don't fully understand yet what is really causing Parkinson's disease. It's not one thing, it's probably a combination of genetics, and we'll talk more about that in a little bit. We have lots of information now about how the environment affects Parkinson's disease patients, and so that's going to be important to pay attention to. We know that there's certain organelles in neurons that are specifically vulnerable to disease, and so that we could think about trying to focus our attention there on therapeutics. And then we also have this protein called alpha-synuclein, which is really interesting to think about and understand more, and how that is related to development of Parkinson's disease and how we might help to prevent its spread. So we'll talk more about that. And as I've been saying, there seems to be this trickiness with Parkinson's disease. And sorry, it looks like some people are saying that the slides are a little bit small and hard to read. Sorry, they may be a little bit hard to read in the room. I'm sorry. I'll try to just speak to that as much as I can. There's no approved medications to help modify Parkinson's disease right now. And everyone is hoping that we can find medications that will be able to slow the progression of the disease. Part of the tricky issue here is that when people develop Parkinson's disease, there's already a loss of a lot of dopaminergic neurons in the brain that have occurred. So there's kind of different phases of Parkinson's disease. We have the motor phase here in time, where people have developed tremor, slowness and rigidity, etc. And that's generally when they get diagnosed with the Parkinson's disease. And then there's actually evidence, though, that there's been some injury and degeneration of the brain going on many years before the symptoms actually were identified as related to Parkinson's disease. And so this was the premotor phase. And so by the time patients are coming to clinic and being enrolled in clinical trials, there's already a loss of a lot of dopaminergic neurons. And so this is a challenge for us to think about to think about ways in which we can try to intervene in the disease when the disease is already pretty involved in the brain. And so we're hopeful that we can find better ways to identify patients earlier before they even have motor symptoms, and then intervene with therapies that'll be more effective. But this remains a big challenge for the field. The other challenge that we have is that we don't have a way to measure the neurons in the brain when someone's alive. We can't go in and say, okay, this person has this many dopaminergic neurons that are still functioning, or this many that aren't functioning anymore. And this is only really able to be counted after someone passes away, if they undergo autopsy. So that's tricky. And so if we give an intervention, we don't really know for sure if it's having an effect on the neurons itself. And so we're left with using these clinical measures to see if we can make a difference to these secondary measures, things like the Unified Parkinson's Rating Scale, or maybe a DAT scan that might have a way to help if someone is better. So we are forced to use these study designs that are not pure, but it's all we have right now. And we can give a symptomatic drug, and we can then follow people over time, and we can see if the therapy that's given after it's stopped, if the patient's clinical state returns to what it would have been if they were just given a placebo. That would indicate that the drug is just helping the symptoms, but it's not really helping the underlying neurons. We might give a drug, though, that actually we give for a while, and then we stop the drug. The patients remain better. So this would indicate that the compound is a progression reducer, or maybe has some kind of neurotherapeutic effect. And then there's even the hope that we'll have drugs that might have a capacity to enhance where someone is now, to be restorative. And so when we withdraw the drug, they actually stay better than they were before they were given the drug. So just wanted to give a little bit of background here and why this is so challenging for us as a field, but there are lots of people thinking about this, and we hope that there may be ways to start to measure the true level of the dopaminergic neurons and alpha-synuclein in the brain soon, with more imaging techniques in the future, as well as better biomarkers. So when we're thinking about clinical trial development, this may be basic for some of you, but just to quickly review, we have different stages of clinical trials. We have preclinical development of compounds or interventions that are either in the lab or in animal models of the disease. And then the drugs move into a phase 1, where this is usually given to just a few patients to make sure that it's safe. We're not really looking for a benefit here. We're just trying to make sure people are safe. Sometimes this is given to patients who don't even have the disease, healthy controls first, and then a few patients with the disease itself. And then if things are looking promising, we'll move into a phase 2. These are studies where we're looking at more patients and thinking about greater, more safety concerns, thinking about dosing of the drug, thinking about working out the best study design to show what the drug could do potentially. And then moving into phase 3, if things are promising in phase 2, lots more patients, not always 3,000 or anything in Parkinson's disease, but still many more patients. Usually a double-blind placebo-controlled trial would be done here. And if things are looking promising, we'll then go to the FDA for review and then hopefully approval if indicated. And then there are sometimes phase 4 studies as well, where lots and lots of patients are followed after marketing of an intervention or a drug. And we're looking for more long-term safety effects and looking to see if there's anything else we can understand. All right, this might be almost impossible for you to see in the big room, maybe live, I'm sorry, but I wanted to just show it anyway because I think it captures kind of some hope for the future. So this is a review article that was published a couple years ago, and this particular figure is showing that there are over 145 active Parkinson's disease clinical trials right now, which is amazing. And what they've done here in this figure, which I like, they've in the circle, so on the outside of the circle are all the phase 1 compounds that are in development. And then here you have all of the phase 2 compounds that are in development, or other, not just compounds, but other therapies too. And then here is the phase 3 studies that are ongoing. So you can see there's a lot. And they also divide this into the upper half of the circle here. These are disease modifying therapies. So trying to get at the underlying pathology in the brain and trying to figure out a way to slow the progression of the disease, not just treat the symptoms. And then at the bottom, you'll see lots of symptomatic therapy approaches. So just lots of incredible work, and it would be impossible to try to review this today just using this venue, but I wanted to just give you the big picture effect. And I've chosen a few things to now just highlight for you. So let's talk about some of the neuroprotective drugs and strategies that are in development. So first, it's good to think a little bit about alpha-synuclein. This is that protein that's misfolding, and it's aggregating, it's clumping up in the neurons. We can see this in the substantia nigra, where their dopamine neuron cell bodies live in the midbrain. And as you all know, that the cells send their axons up to the basal ganglia here and project onto the putamen and the caudate, and that helps the motor system to function normally. And if you look under a microscope, you can see these Lewy bodies that are, and Lewy neurites that have lots of alpha-synuclein inside them. And alpha-synuclein is normal in everyone. Everyone has alpha-synuclein in their brain, but it's in a different healthy type of conformation. It's in a monomeric or alpha helix configuration. And it's only when the alpha-synuclein starts to change and misfold and become these other types of aggregation stages do we start having more pathology. And Lewy bodies are kind of one of the end stages of this, where the alpha-synuclein is being sequestered. But we also can see this in Lewy bodies and Lewy neurites. So we know that alpha-synuclein is really important in normal healthy cells, but when it starts to clump up, we get problems. And so this is just showing a little bit of that in a cartoon here at the bottom of my slide, where you can see over here the healthy alpha-synuclein is helping the nerve terminals to release levodopa into the synapse to help it to lubricate the motor system. And in Parkinson's disease, we have issues with those nerve terminals not functioning correctly and not releasing the dopamine as we would like. So this is important, and a lot of interesting work is going on to try to better understand how this is affecting Parkinson's disease. And one idea is that we could try and target alpha-synuclein directly. We could see if we could somehow attack the misfolded alpha-synuclein. It's been also shown that if you look at pathology in the brain of Parkinson's disease, there is a natural spread of alpha-synuclein pathology in the brain over time. So in the older structures of the brain, in the midbrain and in the parts of the brainstem, we start to see in the olfactory bulbs, we start to see alpha-synuclein pathology early in the disease, and then over time it starts to spread up and through the brain. And so it seems to be related, to the disease progression itself. So if we could prevent the spread of this that would be potentially very useful and helpful for Parkinson's disease patients. And so that's one of the things that's being studied right now, and it's quite interesting. We're using an approach called immunotherapy, where patients are given passive immunization against these pathological strains of alpha-synuclein that are clumping up. This is done by using monoclonal antibodies, which are infused into the patient, usually in an IV like setting. Patients are treated usually every month with these monoclonal antibodies. And there's several ongoing clinical trials seeing if this is going to be helpful for patients. There's a study done by Roche, which is in a phase 2 study, and there's another study that's starting up. I'll talk about that in a second. There's a phase 2 Biogen study studying a similar compound. Unfortunately, that study was found to be negative last year and has stopped. Nonetheless, these other studies continue. There's an AstraZeneca and a Lundbeck trial. So keep in mind, these are all targeting alpha-synuclein in a little bit different ways, with a little bit different ways in which the antibody is connecting to different aspects of the alpha-synuclein. So this is an exciting approach, and we'll see more about this. A little bit about this, the study that's been supported by Roche known as the Pasadena study. They enrolled many patients, and it's an international effort, and showed their preliminary results about a year ago now. And they looked at the Unified Parkinson's Disease Rating Scale in patients who had received either the placebo or just saline infusion versus a low dose or a high dose of the compound, and followed them over time. And there was overall no difference in this combined score, which looks at not just the motor symptoms, but also mentation and quality of life. But when they then looked just at the motor component of the patient's outcomes, just seeing how their rigidity, bradykinesia, and tremor, etc., did, the patients who were treated with the active drug, either the low or the high dose, they were better compared to those with placebo. So this gave the company enough evidence to continue this trial, and it is now in a long-term outcome phase. And they're also starting a new study looking at patients not just with early mild Parkinson's disease, as the first study was, but in patients who are even on a little bit of levodopa. So more to come with this. An expensive study, will be very interesting if this is found to be helpful, how this rolls out. I'm thinking about monthly infusions, but it's definitely helping us to understand a lot whether this approach will be beneficial. It so far seems to be very safe. What about other ways to use the immune system to help us treat Parkinson's disease? Well, people are developing an active immunization approach using vaccines. And it's been kind of fun to think about this as a strategy. Most of this work has been done in Europe. There's a strategy known as epitope, which is actually a vaccine that's been designed to target the alpha-synuclein. And so patients have been now treated with this in a phase 1 study, and it's been shown to be safe. It's also been shown that patients develop antibodies after getting this immunization to alpha-synuclein. They're trying to figure out the best dose to give people. So they've tried high versus low dosing and multiple dosing, with boosters, as we're all used to now with COVID vaccination. And so far, this seems to be relatively positive. They're not seeing any inflammatory processes in the brain, which is good to see, and antibodies are being generated. So more to come. There is a US planned study underway. And there's also a company also looking at developing a vaccine against alpha-synuclein. So this could be something you can imagine maybe would be a little easier to implement, but still a long way to go till this rolls out in any bigger way. But I wanted to point everyone's attention. This is something to pay attention to, and this is moving forward. All right, other strategies to try to target alpha-synuclein and block the aggregation or even enable the breakdown of the alpha-synuclein that's already there, that's in these pathological forms, is to use pills that are usually small molecules. And so there's a lot we could talk about here, but I just listed kind of the top 5 from what I could gather, doing some research now on this for you today. Probably the leading compound is this Neuropor or UBC compound that they're partnering with Novartis. And this is now in a large phase 2 study. It's an international as well study as well as now coming to the United States. It's going to be a Parkinson study group combined effort now. They're looking for a new site. So I don't know if this is going to be a possibility at University of Florida, but we'll be seeing more about this. And the idea is that this will be one of the first oral therapies going against an alpha-synuclein approach. So more to come there. And then just other things to keep in mind. You probably won't want to remember all these little crazy names, but I just wanted to give you hope that there's other drugs coming that are not IV or not, and are not a vaccination. These are not immunotherapy strategies. These are just small molecules that are going right at trying to break down or prevent aggregation of alpha-synuclein. The last one is the second to last one, mannitol, is kind of interesting. This is a drug that's already used in clinical practice for various things. And the UK is doing a study looking at mannitol in Parkinson's disease. They find it to be pretty helpful. They think that that this is going to be potentially promising. So that would not require as much oversight potentially from the FDA. It's already FDA approved, so that's kind of interesting, something to look forward to. It might be easier to get across the finish line. And then, although it's not being supported by any pharmaceutical company because it's already available. And then the last one there, Enterin, is kind of also interesting, and this is a way that we might be able to improve in function of the gut, the neurons that in the gut of Parkinson's patients that have alpha-synuclein accumulation as well. It seems to potentially improve constipation. So more to come. So this slide may also be really impossible to see from the big room. I'm sorry. I just wanted to again give you a big picture idea of how we have in Parkinson's disease this alpha-synuclein that's misfolding that I've been talking about. But there are all these other things that are going on in the neuron. We have things like mitochondria that help our neurons make energy, and also are very vulnerable to inflammation. And so we want to make sure we're not injuring the mitochondria and helping them to be healthy. So there's a lot of interesting approaches to thinking about targeting mitochondria and helping the mitochondria to be healthy in patients with Parkinson's disease and in the dopaminergic neurons. And we also have this whole other way in which dopaminergic neurons are getting rid of waste. And ideally they would be able to, the cell itself would be able to get rid of the misfolded protein that's inside and just say, this is junk, let's get rid of it. And you have a whole system in your cell that does that. And sometimes this waste system is also affected. So we're now hoping that we can find other strategies to also think about influencing these other mechanisms in the cell. And one thing that might be useful is something called the glucagon-like peptide 1 agonist. These are drugs that are already approved to treat type 2 diabetes, and they mimic the human gut hormone to stimulate the release of insulin. But there's also receptors for the GLP-1 that are in the brain. And there's this growing evidence that these molecules may have neuroprotective effects. So they might be blocking activation of these immune cells that can decrease the inflammation. The cells can be more healthy. And this is also, being explored, interestingly, for patients with Alzheimer's disease. So something to pay attention to. What's nice is, again, this has already been FDA approved for patients with diabetes. So, it's a little bit easier to move along the pipeline when that's the case. And there's already been a small clinical trial showing some moderate improvement in motor scores with exenatide. So keep in mind, this is in development and may be useful. We'll see. There's also some approaches to try to target something called C-Abl. C-Abl is a protein that becomes activated in cells when they're stressed. And so if you have overactivation of this C-Abl, you can have downstream issues in oxidative stress. They can play a role in neurodegeneration in Parkinson's disease. And we see that when you have more C-Abl activation, you get more alpha-synuclein clumping up. So it would be great if we could try to inhibit this and boost getting rid of the alpha-synuclein. One of the drugs that's been looked at for this is nilotinib, which it's been approved actually as a way to treat blood cancers. It's a chemotherapeutic agent, and however, it was not found to be helpful in a phase 2 study recently. So one issue is that it may just not work, but it also may be that it was not penetrating the brain enough. So that's always an issue with a lot of these drugs, is trying to get it into the brain. We have a blood-brain barrier, and that makes it more difficult to target. And I just listed a few other drugs below that are all C-Abl kinase strategies that you can just keep an eye on as they move along in development. So we do have specific therapies now coming for different specific gene types that are now understood in Parkinson's disease. We've identified at least 6 mutations of patients that are affecting patients with Parkinson's disease. So if you have mutations in any of these 6 genes, we do think that they are linked to the development of Parkinson's disease pathogenesis. And this slide just kind of shows the different genes that have been described. And there are some of the genes that have been found are more rare. And so, they're rare diseases, and but if you have these, you're very likely to develop Parkinson's disease. But there are other genes that are, not as rare, but they're not as potent. So your likelihood of developing Parkinson's is less. And so I just wanted to give a shout out for patients who haven't been, tested for any of these, to think about it, because we're now going to have new therapies coming, hopefully soon, that are going to help us to maybe target specifically what's going on with these different genes in the pathways related to the mutations. This is one helpful way in which you can get genetic testing through the Parkinson's Foundation. They have a big initiative called PD Generation. And so just, you can go to this website and they will be able to help you get screened for any of these genes. There's other ways in which you can also be tested through clinic and things, but talk to your doctor about this if you haven't been tested. Patients also, it's a little bit about one of these mutations, the GBA mutation. Patients with the GBA mutation have about a 20% increased risk of Parkinson's disease, and about 5 to 10% of patients will carry this mutation out there. It's a very common mutation. So even if you do have this mutation, it doesn't mean you're going to definitely get Parkinson's disease. Your chance of getting PD is still low. And it's much more common in Ashkenazi Jewish descent, or in patients who have relatives or family members with Gaucher's disease, which happens when you have you have 2 mutations for a GBA, then you are likely to get Gaucher's disease. If you just have 1 mutation, though, you're considered a carrier, and you're at increased risk of developing Parkinson's disease. The phenotype of this is a little bit different. So there a lot more is learned now about, how are these patients different than people with Parkinson's disease. They generally have a slightly earlier age of onset. They often have more bradykinesia, a little more rapid and more progressive disease. They can have more cognitive dysfunction, less tremor. So there are strategies to try to really target patients with this type of disease, with GBA, Parkinsonism. And what's important in patients who have GBA mutations is that they have a mutation that encodes for something called Glucocerbrosidase, which is this housekeeping enzyme that breaks down these large molecules in the body that are composed of both glucose and sugar, and as well as fat. And so if you don't have if you have a GBA mutation, you don't have enough of this glucocerebrosidase mutation. And so you start building up all of these insoluble compounds in your cells, and your cells can get laden with this, and they can then start to dysfunction. So we would love to see a way to be specific to increase this activity of this enzyme that's missing. And that's what's happening now. We have these, very specific therapeutic approaches for GBA patients, and I'm just highlighting those here on the screen. This is a nice review paper, kind of thinking about all the ways we could target this from a genetic point of view. And one of the ways that's being explored right now in this Eli Lilly study is using actually a gene therapy approach, where they're giving back a functional copy of GBA. And so they're going to be injecting this into the CSF, and hopefully the functional copy will then create more glucocerebrosidase, which will then lead to better downstream issues, within the cell. Other strategies have been to actually just try to help increase the clearance. And there was a nice study done by Genzyme Sanofi, which really enrolled a lot of patients, and these patients were from all over the world. And this was really the very first industry-sponsored study that was specifically targeting genetically defined Parkinson's patients. So it's quite amazing. And they did show that there was target engagement. This was getting into the brain. However, patients did not do well. In fact, those that were treated with the compound were worse. So this has now been stopped. They're not pursuing development of this anymore, but we learned something. And nonetheless, we did show that, it was possible to recruit these kind of patients and enroll them in a trial like this. There's other still strategies thinking about perhaps a safer way to reduce GBA issues. And so, keep an eye on Ambroxol, as well as this other study that's in phase 2 here by lysosomal therapeutics, trying to increase glucocerebrosidase. What about LRRK2? This is another very common Parkinson's disease genetic mutation. These patients are being found more and more. It's much more common again in Ashkenazi Jewish lineages. And again, the penetrance is not 100%. So just because you have this gene doesn't mean you will get Parkinson's disease, but certainly you're at increased risk. And it looks, the phenotype of this looks very much like sporadic Parkinson's disease. It tends to occur a little bit later. They have a good Levodopa response. So it's a slower progression. So there's lots of therapeutic strategies now thinking about how can we help patients with LRRK2 mutations? What can this do to help us? There are small molecules that are being developed. There's a large-scale study being sponsored by Biogen and Denali, which is going to be a pill that's going to inhibit LRRK2 activity. And they've already shown in phase 1 that this is possible. We have target engagement in the brain, and it was safe. And so this is a phase 2 study that's rolling out this summer. We're excited about this as a potential way in which to use oral therapies to help patients. They're going to be looking at patients with Parkinson's disease, as well as with patients with LRRK2 mutations. So you don't have to have a LRRK2 mutation to enroll. So it'll be interesting. And then also a strategy looking at using something called an antisense oligonucleotide. This is a different strategy where, again, we're trying to move upstream and use a molecule that can bind messenger RNA of LRRK2 and just inhibit its translation into a protein. So basically reducing LRRK2 in the brain, and Biogen is doing this. So we'll continue to watch this and follow. This is going to be a single or multiple injections of this compound into the CSF. That's how this is going to be brought forward. All right, so that was what I wanted to tell you a little bit about the disease modifying agents that are coming up in the near future, that are coming into trials, that are something to watch. But what about other symptomatic therapies? We do have lots of symptoms that patients are experiencing that we have some treatments for. And we have a lot of non-motor symptoms here on the bottom, which are not as well treated. Most of our medications that we have focus on the motor system, trying to improve dopamine, getting across the finish line into the brain. We have all of these drugs that we have that can treat Parkinson's disease symptoms with Levodopa. This is probably hard to read, it's a little bit small, but I mean, we've had Levodopa around for 50 years, and it still is a great drug. I'm gonna just jump because my dog is barking and I'm gonna shut my door. Hang on one second. And one of the things that's happening is that we are trying to find better ways to get Levodopa into the brain at a more consistent level so that we can improve treatment all throughout the day. As you know, patients who have Parkinson's disease will take medications and they'll have a good benefit, especially in the early stage of the disease. It can be very helpful. But as the disease advances, we have a lot more wearing off of medication effect. People have to take the dose much more often. And that can be really challenging for patients to have improved on time throughout the day. There's some strategies. It sounds like there's going to be a talk about this later in your symposium, thinking about how to change the microbiome in the gut to have Levodopa potentially be more readily absorbed. So there are certain gut bacteria that actually can break down Levodopa. And so we would like, maybe there's a way we could kind of influence the gut bacteria so that we could have more reliable Levodopa absorption and increase off time. There's also some interesting ways in which Levodopa is being packaged. This is something called an accordion pill. And this is allowing the drug to be kind of stuck in the stomach for a little bit longer. And slowly, it's wrapped up inside this little capsule, which would then be dissolved. And then the Levodopa will be able to be slowly released into the rest of the gut. So I don't know if this is going to really move the needle a lot, but I thought it's kind of interesting. And I wanted to talk and point that out today. They did do a phase 2 study, which had disappointing results, but they're planning another study. They think maybe the way it was dosed and designed wasn't quite right. So that is going to move forward. There's also this interesting way in which people are delivering Levodopa through something called DopaFuse or OraFuse. This is a retainer-like device that has Levodopa inside of this little container aspect, a mini pre-filled container. And it's you can put this in your mouth. It's like, made for you specifically, obviously. And it just will drip, drip, drip a little bit of this Levodopa paste throughout the day. So that's pretty interesting. You have to remove it to eat, etc. But there's also a phase 2 study looking at this again, trying to get Levodopa into the body in a consistent way. As we know, Levodopa can help. There's also ways in which people are investigating Levodopa being administered into the skin. So this is being developed by Neuroderm as well as AbbVie. Through a pump patch-like strategy. So this is in late stage phase 3 studies. This is likely to come to market. So this is something to watch out for if you're having a lot of Levodopa fluctuations and you don't want to think about deep brain stimulation. This is something that you can consider coming. There will be some skin issues, I think, with this. So you can get skin nodules where this little infusion site goes into the skin and stays for 24 hours and then gets moved. There can be little nodules under the skin that develop, which go away. They're not, dangerous, but they're very common and may be a barrier for this therapy. And then we also have apomorphine, which has been available in Europe for a long, long time, but still not available in the United States. This, may be coming to the US eventually, similar kind of strategy, but using apomorphine, not Levodopa. Okay, so I don't have much more time. I was just gonna mention though that there are lots of other non-motor symptoms of Parkinson's disease, and we have lots of ways we treat these in the clinic, but most of these drugs that we are using in the clinic to treat the non-motor symptoms have not been tested in patients with Parkinson's disease very much. So a lot more work needs to happen in this area to figure out specifically for Parkinson's disease what is best. And I don't have enough time to talk about that today, but I just wanted to recognize that that's still an unmet need and needs a lot more attention. There's going to be another talk today about deep brain stimulation. I encourage you to go. There's a lot of excitement in the future of DBS. This is this treatment where you have a brain-like pacemaker that delivers chronic electrical activity to the brain and has been around for a long, long time now. It's very potentially helpful for patients with specific motor symptoms. And there's lots of incredible technology advances here too. So we're getting better at steering the stimulation around in the brain, the specific spot it should be. We're getting better at targeting the brain in exactly where it needs to go. And we're getting a lot better at optimizing stimulation settings quickly. So lots of wonderful things happening with advancements with DBS. We're getting better at also learning about how the brain is affected by Parkinson's disease, the physiology of the brain, because now not only can we stimulate the brain, we also can record off of the brain electrode. And this is really exciting because we are learning a lot about the pathophysiology of the brain. And the more that we can find signals in the brain that are important to track, the more we may be able to use those signals to then auto-stimulate the brain in a very adaptive-like way, much like a cardiac pacemaker only paces when there's an arrhythmia. So we may be able to have a strategy like that as well for deep brain stimulation. All right, I'm going to move ahead now, and I'm not going to show you that one. I kind of talked about that. Focused ultrasound is also coming. I think this is going to be touched on in the later session. So pay attention to this. This is a way in which we can create a lesion in the brain, but we don't have to open the skull. And this is being used quite a bit in patients with essential tremor who just have tremor. And it is also being now studied in patients with Parkinson's disease, just on one side of the brain. So just treating tremor on one arm or one leg or one half of the body. But this is something that is potentially going to be useful for patients who have Parkinson's disease tremor. So just something coming, and we'll see if we can learn more about this in the coming years. One shout out for gene therapy. Gene therapy has been in development for many years, and lots of different strategies about thinking about how to, what kind of gene do we want to put into the brain to try to change what's going on in Parkinson's disease. There's different strategies. And we've targeted the subthalamic nucleus with certain genetic approaches to try to quiet down this area of the brain circuit. That's been reasonably effective. We've tried to inject agents into part of the putamen to try to increase enzymes that will help levodopa work better. And that's still been reasonably promising as well. And we've also used strategies where we're increasing growth factors in the brain. This has been safe, but not really as useful so far, although there's some still work going on with GDNF. So pay attention to this. These studies continue. There hasn't been huge safety issues, and it is feasible to do this, but the problem is kind of distribution in the brain. It isn't easy to get this everywhere by using these neurosurgical techniques. It's just very easy to get it into one area of the brain, which is a limitation. And I think I'll skip over that. And then everyone always wants to know about stem cell therapy and what's going on with that. Just wrapping up, we have shown, over the years that we can grow cells, that we can harvest them, we can implant them into the brain, the cells can grow, and they can make dopamine. And there's been lots of issues over the years with just ethical problems with getting, human fetal tissue, obviously. And now we can actually create some of these stem cells from early pluripotent cells. So we don't need to use fetal tissue anymore. We can create these stem cells from other cells. It's amazing. We can take skin cells and we can make them into a stem cell now. So that's really exciting. We also can make these cells so that they're not going to cause an immune reaction, so that they don't, so that we don't cause a lot of inflammation in the brain, which and be rejected by someone's body. So that's been a big breakthrough too. But the issues, there's still a lot of barriers to this. First of all, where you're placing these dopaminergic cells in the brain, that is, even if they were to make dopamine, that's not the whole story, right? So this is a systemic disease. And just by replacing the dopaminergic cells in the substantia nigra, for example, that may help some of the motor symptoms, but it's not going to help all the symptoms. And we already have pretty good motor treatments already, don't we? However, this is going forward. There will be studies happening with looking at stem cell approaches still here in the future. And I do think it'll be a more sophisticated approach. And this may have a role to play for some patients. And I just wanted to say one more thing about stem cells. Beware that there are a lot of people out there trying to sell you the cure for Parkinson's disease. And people are taken advantage of, and there is a lot of evidence that patients are sometimes harmed very much so. So please, if you're thinking about, something like this, I want you to be really careful that you do your research and make sure that you check things like clinicaltrials.gov. Go to this website and make sure that the study is registered there. If it's not registered there, I'd be very wary about participating in that, because people can be taken advantage of. It's very costly, and it can actually be very damaging to some patients. And then lastly, I would have loved to have talked a little bit about future therapeutics in other things like physical therapy. But this is actually one of the most important things you can do, and it has been shown to be neuroprotective. It's maybe one of the only things that we have out there right now. So I just wanted to remind you that movement is therapeutic for movement disorders. So lots of exciting improvements here too, as well as trying to be very specific for what is going to be most useful for patients with Parkinson's disease. But keep moving is my last slide for you. And then just a little shout out to my team at UCSF and all the wonderful people I work with there. And if you're ever in San Francisco, please come by and say hello. We would love to say hi. Thanks, everybody. Sorry, I ran a little bit over, Irene. Back to you.
Check in. Oh, thank you. Thank you so much, Dr. Ostrem. That was incredible. So I'm sure that many of you may feel like, wow, that was so much information. And that's what's really exciting, is there's a lot going on now. Lots of different approaches trying to find ways that we can slow down or stop Parkinson's, new medicine. So there's so much on the horizon. It's very exciting. If anybody has questions about anything that Dr. Ostrem just talked about, you can write your question on the papers at your table and just put your hand up. And we have 3 volunteers in the back of the room that will come and carry your question to the front. So I just want to give you a minute in case anybody has a question while we still have Dr. Ostrem with us.
Dr. Ostrem, we have one on Zoom as well for you. If you can read the chat, there's a question in the Zoom chat for you.
Oh, okay. Hi, can you still hear me?
We can.
Okay, good. So I think the question is there any progress on hyperbaric oxygen? I actually don't think I know the answer to that question. Certainly, we know oxidative stress and free radicals and things like that, like I was mentioning, can be not so good for dopaminergic neurons, which have these mitochondria that are really, really active. And so I suppose that's the strategy that people are going for with using hyperbaric oxygen. I don't know of any clinical trials though that have really looked at that specifically. So I cannot endorse that as a therapy. I think I would be cautious about that.
Yeah, I think that's one of those therapies that keeps reemerging in different disease states. Hyperbaric oxygen, there's always a hope it will offer something for different diseases, but nothing in Parkinson's right now. So Dr. Ostrem, we have another question. Why is focused ultrasound only approved for one side of the brain?
Yeah, and I'm sorry, I was kind of trying to go a little bit too fast there, maybe at the end. I was worried about my time, but focused ultrasound is creating a lesion in the brain. So it's using this focused ultrasound energy through the skull into this area of the brain, which is responsible for movement, but is probably functioning kind of abnormally. And so if we injure the cells there, you know, on purpose, sometimes we see pretty amazing improvement in tremor. And so we also can adjust the function of these neurons with deep brain stimulation. But we can't injure the brain, creating a permanent lesion on both hemispheres. And if we do that, we will get more side effects. People will have troubles with speech. People may have trouble with swallowing, maybe even cognition. So, and it really depends on where in the brain you're lesioning, but we can't do it, you know, safely in both hemispheres, at least right now.
And I see questions rolling in the chat that I believe you can see, Dr.
Yeah,
Ostrem.
like,
if anyone else in the room has a question and you want to write it, just raise your hand and we'll have someone come grab it from you.
There's a question that says, is there any study looking at neuron function in addition to just producing dopamine with respect to neuron replacement? Yeah, I mean, it's hard. The problem is that we don't have any way to really know how the neurons are exactly functioning. We just don't have a great way to measure that. So not really. I would say, you know, there's probably animal models looking at that, of course, right? Where we can do something to a mouse and then we can sacrifice the mouse and count the neurons, but it's still a real challenge in the field. There's another question. What are the most common comorbidities with Parkinson's and how does treatment of them interact with the diagnosis and treatment of Parkinson's disease? Well, I think people that have risk factors for hypertension or who have diabetes, they are more likely to have less improvement with Synuclein sometimes because there's can be more injury to the brain. Just the small vessel diseases of the brain can mount a little bit more of a challenge for some of the medications to be effective. Certainly other medications we use to treat Parkinson's disease non-motor symptoms, you want to make sure there's no drug interactions going on. There's probably a lot to unpack with that question, so really talk to your doctor about what's going on. There's one more question here. Want me to keep going? Okay. Although there are many medical studies in development taking place, knowing that the disease is slow moving, is it fair to say that new meds will also be slow to be developed and available? I don't know. I would say, you know, you can't do a neuroprotective study unless you follow people for some period of time. That is a real problem. But we are doing a lot of great work now to find biomarkers of disease progression. And if we get clever enough and maybe lucky enough, we can then speed the process up where we don't have to just wait for patients' symptoms to tell us exactly whether they're better or not, but we could, you know, measure something in the blood that's telling us, or measure something in the cerebral spinal fluid, or do a scan that will help us to know that the drug is doing something. So there's a huge effort going on to find a biomarker for Parkinson's, not just to diagnose disease, but also to show that, you know, we can measure progression.
I think we'll take one more question that's being actively written in the room. And if you have one more on the chat, and then we'll move to the next presentation.
Okay.
If you want to take the one in the chat, that'll give us a minute. In the chat?
Okay. Okay, here's one. Are you aware of any results from the DBS study in France using NIR? I'm not sure what NIR means. Dr. Malati, do you know?
I don't know what NIR. Adolfo, have you heard of NIR?
Oh, near infrared light.
Oh, okay.
A very advanced question. I don't know. I'm sorry.
I'm not familiar with DBS and infrared therapy. There are studies with light therapy and trying to stimulate regions of the brain with different frequencies of light. I'm not sure if that overlaps, but I think that we don't have any updates on that kind of therapy yet. Well, this question, I might need a little clarification. It says the use of multiple beams of ultrasound will reduce damage to the brain, but the small volume of intersection will provide good information. Was this a comment that maybe we'll learn from what happens with these? Okay, so this was just sharing a comment that, you know, we can actually really focus those beams and make a fine area of lesion. And I think the comment was this will really teach us a lot about what happens in the brain. And that's true. In fact, lesion therapy came even before deep brain stimulation therapy. It was the old way to burn a hole in the brain. And then we learned that we could use electricity to stimulate an area and make it functionally like a lesion without a permanent lesion. And so this is sort of another version of an old therapy to use ultrasound instead of making an incision and going in and making a hole in the brain. And you're right that as we've discovered what happens, the good and the bad from these procedures, we are learning more about the brain circuits and how these therapies can be more fine-tuned. So thank you so much for the questions and comments. And also thank you so much for Dr. Ostrem. We sure appreciate you still being with us. And we're sorry that you've got some health speed bumps in the family. We hope everybody's healthy and back to themselves very soon.
My
Let's keep Dr.
pleasure. I hope you
Ostrem
have a wonderful rest of your symposium and enjoy all being together and learning all we can about Parkinson's disease. Thank you so much.
Thank you.